All right, let's begin with an introduction to the concept of metabolism. And metabolism basically means what you're put in your mouth, your body takes it, metabolizes it, and uses it to maintain homeostasis. So the concept of metabolism, again, how it relates to adrenal cortex insufficiency and adrenal cortex hyperfunction. A little patho, because I think if you understand the pathophysiology of the adrenal gland, you can understand why the patients have the symptoms that they do. So the adrenal gland sits on top of each kidney, and you can see it right there in the picture. Each gland has an inner core, which is called the medulla, and there's a thick outer covering called the cortex. And both of these have distinct endocrine functions. This exemplar is going to focus on that outer covering, that adrenal cortex, and its endocrine functions. So under the control of the anterior pituitary gland, the adrenal cortex secretes glucocorticoids, which is cortisol, mineralocorticoids, which is aldosterone, that's the primary one, and sex hormones, the androgens and the estrogens. We focus primarily on the glucocorticoids and the mineralocorticoids in this lecture because basically they have the biggest impact on the body. I do mention sex hormones, but very little. So let's go over some of these functions. Cortisol, as I said, is the primary glucocorticoid, and its actions include carbohydrate, fat, and protein metabolism. That means you eat those foods that contain them, it metabolizes it and allows the body to use them. Cortisol also suppresses the immune system. So think about it, your patients who are on corticosteroids, their immune system is suppressed and they are very prone to infection. It also controls the body's response to stress. We'll talk a little bit more about that. Aldosterone is the primary mineralocorticoid, and its primary actions are to promote sodium and water resorption and potassium excretion in the kidneys. So if you have too much mineralocorticoids, you're really going to absorb sodium and water, and you're going to be adenomous, and you're going to excrete potassium, so you're going to be hypokalemic. So that's kind of how this works. The sex hormones, again, very little the androgens and estrogens, and when I talk about the manifestations, that's when I'll come back to them. So in the last slide, I made some mention of that adrenal cortex secreting the mineralocorticoids, the glucocorticoids, and the sex hormones, but they're under control of the anterior pituitary gland. So we have this HPA axis. The hypothalamus and the anterior pituitary and the adrenal gland are connected to the central nervous system, and they are also connected to the endocrine system. So together, they work to adjust the balance of hormones in the body and affect the body's stress response. So the pathophysiology of adrenal insufficiency, not enough cortisol or aldosterone, could be due to a decreased secretion of the right up here, the hypothalamus, the corticotropin releasing hormone. Or it could be a decreased secretion of the adrenocorticoid hormone, the ATCH, from the anterior pituitary gland, or it could be a decreased secretion of cortisol or glucocorticoids from the adrenal gland. So let's take it a step further. Primary insufficiency or Addison's disease may result from the destruction of the adrenal gland. So your problem isn't with the hypothalamus, it's not with the pituitary, it's with the adrenal cortex. That's your primary. So usually with primary, and Addison's is a very good example, it's a non-specific autoimmune destruction. That means your immune system is attacking itself, and the area that's attacking is the adrenal cortex. And that is what actually Addison's disease. There's other causes, though, of an adrenal cortex insult, and that could be infections, could be cancer, and a traumatic process. So you're in an automobile accident and you get hit, in the kidneys, the back, and you have that insult to the adrenal cortex from that trauma. So when the circulating levels of cortisol and aldosterone fall, the hypothalamus and the anterior pituitary gland, they recognize that. So when the levels fall here with the adrenal cortex, the hypothalamus, the pituitary are saying, oh no, we got to do something about it. So they secrete more of the CRH and the HCTH in primary. I'm going to move on to secondary now and tertiary. Secondary means your anterior pituitary is the problem. So if your anterior pituitary is the problem and it's not secreting enough ACTH, then the adrenal cortex can't secrete its cortisol and aldosterone. I don't go much into that, but I did feel that I needed to mention it. Now with tertiary, it makes sense that the hypothalamus has to be the culprit somewhere. So tertiary is when the hypothalamus is not secreting enough of the CRH, which then in turn causes the HCTH to drop, and then it decreases the cortisol and the aldosterone. It really doesn't matter which one it is, if it's primary, secondary, tertiary, when we talk about how it presents. They basically all present the same. The manifestations of adrenal cortex insufficiency, regardless of the etiology, is all going to look the same. Females are most affected, and it has a peaked incidence in people 30 to 50 years of age. Now, I just said a mouthful. So let's do a connection check here. The nurse recognizes which patient is at greatest risk for adrenal insufficiency. So let's look at A. First of all, is it the males? And I just said, no, it's females. So let's throw A out. We can throw C out too, right? So let's look at the two that have female in them. Is it a 35-year-old female or an 80-year-old female? And as I said, it's females between the ages of 30 and 50. So our answer would be B. Now let's relate it to somebody you may know. I know a lot of you are young and you don't remember John F. Kennedy, but I do. So John F. Kennedy was the 35th president of the United States. And he always looked suntan. He had this vigorous image. He was very young. He was in his 30s when he was elected president. And I don't know if you remember hearing the stories, but he was one of the first presidential debates that was televised, and he debated Nixon. And so you have Nixon, who appeared very pale on camera. And of course, he was older than Kennedy. He didn't look as vigorous, but Kennedy's suntanned image kind of, they say, is what threw him over the threshold and allowed him to win. But there's a little irony to this story. The hyperpigmentation of his skin was due to the inability of his adrenal glands to produce cortisol and aldosterone. He had Addison's disease. And his Addison's disease, as I said, Addison's disease is an autoimmune problem, right? It attacks the adrenal gland. So he, his was primary. So when his adrenal glands failed to produce adequate amounts of cortisol, the pituitary gland and the hypothalamus recognized it. And so to get the adrenal gland to produce more cortisol, they increased their secretion of the CRF and the HCTF. Now, the HCTF, that hormone that's secreted by the pituitary gland, has a common hormone with the melanocyte stimulating hormone. So melanocyte, you probably remember that from skin. That is what darkens your skin. So that associated increase in that melanocyte stimulating hormone and the HCTS leads to that darkened bronze hyperpigmentation that accompanies Addison's disease. He was diagnosed at the age of 30. So I'm going to ask again, was it primary, secondary, or tertiary? It's primary. So we're going to talk more about the clinical manifestations of Addison's disease or adrenal insufficiency. All right, so we know when there is an insufficient amount of adrenal cortex hormones, we're going to have symptoms. So secondary to that, your client is going to present with that hyperpigmentation, but weakness, weight loss, fatigue, nausea, abdominal pain, gastroenteritis, and emotional lability. This change in mood may include irritability, depression, and an inability to concentrate. So here's where your sex hormones come in. Secondary to a decreased secretion of the sex hormones, it can lead to a thinning of the pubic and the axillary hair. When we look at aldosterone, secondary to the loss of sodium and water, the client's going to present with dehydration and hypotension. And then the inability of the patient to excrete potassium can cause these dangerous arrhythmias. So if you get a test question now, we give you the range. So if you see either hypo or hyperkalemia, that really puts your patient at a high risk for dysrhythmias. So let's take a moment and connect the dots. All right. We know that cortisol promotes fat, carbohydrate, and protein synthesis. So if it's insufficient, what are we going to see? Let's look at onto the other side. What are we going to see? So if you can't metabolize the fat, the carbs, and the proteins, you're going to be weak. You'll see weight loss and fatigue. We know it also suppresses the immune response, right? Cortisol. So what are we going to see? We'll see B, yes, very good. That's slow, long-term inflammation. We know it controls the body's response to stress. So what are we going to see? C, that irritability, that depression, that inability to concentrate. Remember, I said the mood, we're going to see some alterations in their mood. It promotes gluconeogenesis. That means it increases blood glucose in response to stress. So if I don't have enough, what am I going to see?
Hypoglycemia.
Yes, we're going to see that. So this is a thing that I just want to hit home to you. A lot of you in clinical, your hospitalized patients, you're going to see an increase in their glucose. So, when you give a reason on your lab sheet, I don't want to hear you say, well, they're eating foods that have sugar in it. No, the reason is because they're under stress. And when the body's under stress, it releases glucose into the bloodstream, which allows the cells to uptake it so that they have the energy to fight, to flight, or freeze. So that's why you would see that increase in glucose. I digress. Let's go on to the next one. The ACTH, that precursor molecule to the melanin stimulating hormone. What are we going to see with that? That hyperpigmentation, right? As in President Kennedy's skin. G. And then, yes, G. And then promotes sodium and water reabsorption. If I don't have enough, what am I going to see? If I can't promote it, I'm going to see E, the dehydration and the hypotension. And then again, if I don't have enough of these hormones, I can't promote potassium excretion by the kidneys. So what does that do? It makes me hyperkalemic, which puts me at high risk for dangerous arrhythmias, which would be A. I got another one here for you. The nurse correlates which clinical manifestation with the pathophysiology of adrenal insufficiency. Is it heat intolerance? Is it weight gain? Is it peripheral edema, or is it hypoglycemia?
Hypoglycemia.
Yes, very good. And this is the kind of questions that you'll probably see on your test, because we have to know that you understand what happens when we're deficient in these hormones. So diagnostic testing. So diagnostic testing of adrenal insufficiency includes tests of the hypothalamus pituitary axis and adrenal cortex, as well as serum electrolytes. So we know what serum electrolytes we're going to be looking at. So direct measurement of serum cortisol levels, and you can see where I have right here at the top cortisol, right? Because that's one of the hormones that the adrenal cortex secretes. In the morning, a normal range would be between 5 and 25, and in the afternoon, it's a little lower because you're using it up as you go about your day. So it's always highest in the morning. So any level up to about 25 mics per deciliter is considered normal. So when you do this test, you want to test them in the morning, right? When they have the most amount of cortisol in their bloodstream. So levels that are less than 3 mics per deciliter, they're diagnostic for adrenal insufficiency. So what would they do? They would do a serum corticotropin, can also be obtained. They could look, if your cortisol is low, then they may look at the ACTH. They may look at the other hormone from the hypothalamus and see if they're low too. If the ACTH is high, because now it's time, if it sees a low cortisol, the pituitary gland is trying to compensate by dumping more of the ACTH, trying to get that adrenal gland to produce more. So levels of that ACTH should rise. And if they're over 100, then that's diagnostic for primary adrenal, meaning the adrenal gland is the issue. Glucose kind of makes sense why we would look at that, right? So if we're looking at serum glucose, we expect that they're going to be hypoglycemic. If I look at potassium, serum potassium, they're hyperkalemic. Sodium would fall, right? Because they're not holding on to it, right? They're dehydrated. So a low level would be another diagnostic tool. And then imaging studies. So they only use imaging studies if they want to assess for changes in the size and the morphology of the adrenal gland. So they're looking to see if it is a primary and how much of the adrenal gland has been damaged by the autoimmune disease. So shrinking, again, would be autoimmune. Enlargement of that gland would tell you that it's an infectious process. Does that make sense to you? And you have copies of these slides, so it's a good way to kind of work through it. So medical management. So how do we manage it? And now we're talking about primary. Replacement of cortisol is the definitive treatment of adrenal insufficiency. Patients who present with acute adrenal insufficiency, right? Acute, meaning it's happening now, it's not chronic. They require emergency stabilization with IV fluids and glucose. So you want to give fluids, right? They're dehydrated. They're not holding on to their sodium and water. So, and they're also hypoglycemic. So if you can give a fluid, I mean, normal saline's okay, but D5W is better. It has the glucose in it. You also want to give IV administration of the glucocorticoids, such as hydrocortisone, sodium succinate. That's a good one. It contains both the glucocorticoids and the mineral corticoids. That's the advantage. And then dexamethasone, again, which is a corticosteroid. That would be another. And it's IV administration. Usually it's a push. The patient who is getting these IV administrations of cortisol is going to require close monitoring. You want to do frequent vital signs, always assess their level of consciousness, look at their serum sodium, their glucose, their potassium levels, because they're going to ensure that you're giving an adequate dosage of cortisol. In patients who present with hyperkalemia, there's treatment with potassium binding or excreting agents like Kayexalate. So who knows how Kayexalate works? And has anyone ever given it? You see it a lot with your chronic renal failure patients, or maybe your liver disease patients that have high potassium levels. So they drink it. It's a liquid. It doesn't taste very well. You can also give it per the rectum for patients who are so confused that you don't want to give them something by mouth. But what it does is it binds with the potassium in the lumen of the GI tract, and then that binding of the potassium reduces the concentration of potassium in the GI tract, resulting in a reduction of serum potassium levels. So it binds with it, and then you excrete it out through your stool. So how do I know if it's working? Well, first of all, they're going to have numerous bowel movements, and that's what you want, because you want them to excrete it. And you want to tell your patient that, and you want to have them close. You know, a lot of times you'll put a bedside commode there because they're going to go often, and it may be very quickly. And how do we know it's working? Again, we're going to be checking potassium levels. So the big complication is that acute adrenal insufficiency, which is otherwise known as adrenal crisis or Addisonian crisis. It is a life-threatening emergency. It leads to severe hypovolemia and hypotension. Because of the decrease in aldosterone and cortisol, the patient loses sodium, accompanied by fluid loss. The patient is also at risk for hyperkalemia and hypoglycemia associated with the lack of both mineral corticoids and the glucocorticoids. The patients who are at high risk for this adrenal crisis are those patients who have an underlying adrenal hypofunction, and they undergo a stressful event such as trauma, surgery, and infection. So let's think about our patients with Addison's disease, and if they have something that would stress their body, a stressor, say surgery, you want to up their exogenous corticosteroids. They want to give them more so that they, their stress response would be adequate. Another thing, people who get exogenous corticosteroids for longer than 2 weeks, if you abruptly take them away, they're at high risk. So this is how that works. So you're giving someone steroids, say they have an autoimmune thing, rheumatoid arthritis, Crohn's disease, and you're giving steroids because you want to kind of cut down on that inflammation. So you put them on high dose steroids, and then all of a sudden you take them away. The adrenal gland, when you're giving, and they say exogenous corticosteroids, coming from outside the body, the adrenal gland goes to sleep. What it's saying is, oh, I have, the corticosteroids, the mineral steroids, I don't need to produce any on my own, so I'll sleep. When you abruptly withdraw them, you got a sleeping adrenal gland, so you're not producing anything. That's why you titrate. You take them off them very gradually. You give that adrenal gland a chance to wake up and do its job. Does that make sense? That's why we titrate steroids. So let's do another connection check here. Fluid volume deficit, hypotension, and decreased cardiac output is associated with what? Would it be a lack of cortisol or a lack of aldosterone?
Aldosterone.
Very good. Risk for unstable blood glucose levels are associated with what? Cortisol or aldosterone?
Cortisol.
Very good. So body image disturbance is associated with what? 1, 2, or 3?
One.
1. Yeah, and now that you think back on it, and have you ever seen people that look perpetually suntanned and you're thinking, so for them, it could be embarrassing to them because there's basically nothing they can do about it. So think about that as a body image disturbance. So teaching. You want to teach your client to take their oral replacement daily, right? Because if the adrenal gland is insufficient, it's not making enough, you got to replace it. And it's required, right? Because you want to maintain fluid balance and normal glucose levels. You want them to always wear a medical alert bracelet because it'll reduce the time to definitive treatment in an emergency. So patients who have Addison's who are in a car accident, if they don't know that they have Addison's with insufficient hormones, that stress could put them into that crisis. It's also important that the family and the patient detect the early signs of adrenal insufficiency because it can deteriorate to that crisis. Again, that's that life-threatening situation. And if you give an over replacement of the glucocorticoids, it's going to result in adverse effects too. So you need to know the signs of excess, and we're going to learn about them in the next several slides. But not before we start a connection check. A patient has been receiving doses of prednisone for treatment of rheumatoid arthritis for the past 3 months. If this medication is suddenly discontinued, for which complication is the patient at risk?
Hypovolemia.
Very good. Very good. Again, these are these application questions that we talk about when we say, we're 80% application. So we're almost there, right? Let's go on to the next slide, and we're going to talk a little bit about not insufficiency, but excess. So let me draw your attention to Henry VIII. He was immortalized as a domineering king, a notorious philanderer, and an unlikely benefactor of a new church. He was a legend during his own reign. He was England's most infamous ruler. He had 8 wives, didn't he? Beheaded one of them because she couldn't give him a son. So after 35 years in power, Henry VIII was bloated, hideously obese, ill-humored, and rarely seen in public. It has been theorized that he had Cushing's disease. So, the epidemiology of adrenal cortex hyperfunction is basically the opposite of adrenal cortex hypofunction. There are some slight differences. Adrenal cortex hyperfunction may be secondary to excessive secretion of glucocorticoids or excessive secretion of aldosterone. They kind of separated here with the hyperfunction. Don't do that so much with the insufficiency. So hypercortisolism is characterized as primary. So who's the culprit? The adrenal gland. That means it produces too much glucocorticoids. Secondary, who are we blaming it on? The anterior pituitary. Or tertiary, the etiology is the hypothalamus. Kind of in line with what we just talked about with insufficiency, primary, secondary, or tertiary. So let's talk a little bit about the term Cushing's. Cushing's is often used to describe the hyperfunction of the adrenal cortex. Cushing's disease describes a condition caused by excessive hormone production from an anterior pituitary tumor, which is about 70% of the cases, or excess secretion from a pituitary tumor of the adrenal cortex, which is about 15%. So Cushing's can be primary or secondary. Most often it is secondary, about 70% of the cases. Now, Cushing's syndrome is another term. It's broader, and it's used to describe an excess of hormone production somewhere on the HPA axis or administration of exogenous corticosteroid medications. So the broad term of Cushing's syndrome can be anywhere on that axis, but it also includes when you give too much steroids. Again, just like insufficiency, despite the etiology, the clinical presentations are similar. They're going to look the same. Our symptoms are going to be the same. Females are 5 times more likely to develop this, just like insufficiency. And the peak incidence of hypersecreting tumors of the adrenal and pituitary glands is usually in the 25 to 40-year age range. Now, patients may also present with hyperaldosteronism, which is referred to as Conn syndrome. Because the primary actions of aldosterone are sodium and water resorption and potassium excretion, these patients are going to see hypertension, they're holding on to that fluid, and hypokalemia, they're getting rid of the potassium. The incidence of Conn syndromes is significantly greater in African Americans than Caucasians, and there is a strong pattern of inheritance with females more at risk than males. So I always wondered if, when they say that African Americans high blood pressure, is it more patho-related, meaning that the excretion of fluids or of sodium and water has something to do with their physical makeup and not lifestyle choices. Well, the clinical manifestations of hyperfunction are directly related to the hypersecretion of these hormones, and they include hyperglycemia, fluid retention, hypokalemia. There's abnormal fat distribution. Remember, if we have too much and we're metabolizing fat, well, we're metabolizing it, but in all the wrong places. We also see a decreased muscle mass with muscle weakness. That maldistribution of fat and changes in muscle are related to the effect that glucocorticoids have on fat and protein metabolism. Physical features such as an upper body obesity with thin arms and legs, a buffalo hump of fat on the back, round, red, and puffy looking face. It's called a moon face. And you'll see this with people who are giving steroids for Crohn's or some other autoimmune. And once you pull the steroids off of them, they go back to looking normal. They're thin, easily bruised, slow healing skin and ulcers. This all supports the diagnosis of Cushing's syndrome. There's one common psychiatric symptom reported during illness, and it's atypical depression. So it's depression without any cause. In female patients, now we're going back to our sex hormones, clinical manifestations include developing male sexual characteristics such as breast atrophy, their breasts shrink, their voice deepens, there's an abnormal growth of hair on the face and body, and loss of menses. In males, the loss of plasma testosterone levels can cause impotence and a loss of libido. The overproduction of cortisol also affects the immune system by decreasing inflammatory and immune responses. Lymphocytes are also destroyed secondary to high levels of circulating cortisol, further placing the patient at high risk for infection. So let's look at how we diagnose this. And it kind of looks the same as what we looked at the adrenal cortex insufficiency. So again, we're going to look at our cortisol levels. They're going to be elevated. We take them in the morning, right? Because aldosterone secretion results in both water and sodium resorption. So when we look at sodium, it could be within normal limits. So I want to explain that a little bit. So if they're holding on to both sodium and water, the sodium could dilute out, or the sodium could be diluted out by the excess water that it's holding on to, meaning that the sodium necessarily could remain in normal limits. The patient will present with hyperglycemia secondary to both glucocorticoid activity and hypokalemia. So I don't know if you had this in 180, but we know that as potassium moves out of the blood and into the cells, glucose is going to move out of the cells and into the serum. So they kind of have that inverse effect, like calcium phosphate. We have it with glucose and potassium. Measurement of urinary free cortisol is used as an initial screening because it measures urine cortisol during a 24-hour period. If your urine test reveals abnormally high levels of cortisol, you may be diagnosed with Cushing's syndrome. The overnight dexamethasone suppression test is another tool to diagnose hypercortisolism. So in chapter 76 in your ATI book, on page 513, it gives a really good explanation of this test. I'm not going to go into it because I think that does a really nice job. So how are we going to manage it? We're always going to focus on preventing complications associated with fluid overload, changes in their immune status, changes in their skin integrity, and changes in body structure. So what do we want to monitor with respect to fluid overload?
Their weights.
Their weights, very good. Any vital signs?
Whether low or hypertension.
So they would hypertensive, right? Their blood pressure would go up, very good. We always want to monitor, right, their serum potassium, their I's and O's, serum glucose. What are some nursing actions specific to skin integrity? Because remember, I said their skin gets dry, they get these ulcers. So we want to turn them frequently, and we want to protect their skin from injury. So if you have to move a patient, you kind of want to lift them and move. You don't want to pull them across the bed. Again, teach them right not to use hot water. Lukewarm hot water is just going to dry the skin out more. You want to use a water-based emollient on the skin. What are some nursing actions related to fluid overload? If your patient's fluid overloaded, what do you want to do?
A fluid restriction.
You could do a fluid restriction, yeah. What about the head of the bed? We want to elevate it, right? To about 45 degrees at least. And then if they need oxygen, we're going to apply it if it's appropriate. Now, there are some medications that interfere with ACTH and glucocorticoid production, and that's what we use in the treatment of hyperfunction. There are two examples given. The glutamide interferes with cortical production, and then the criprohepidine impacts ACTH production. I don't expect you to memorize those two meds, but you have to know that there are medications out there that do suppress adrenal cortex hormone production. Management, again, is also going to focus on controlling that hypertension that somebody said, and we want to manage the hypokalemia. So we treat the hypertension with spironolactone, and that's your potassium-sparing diuretic. Also monitor both their potassium and sodium levels when they're on this medication. And then for those who are hypokalemic, potassium supplementation like a K-rider may be required because of the potassium leaving the serum. Surgical management. Let's move on to that. We're almost there at the end. It's based on the etiology of the disorder. If the etiology is a pituitary tumor, a transsphenoidal hypophyseectomy is performed. We talk more about this when we discuss the thyroid disorders, but I can tell you that I would go over that. It is in your ATI, that MedSurg ebook. If you don't have the hard copy, there is an ebook. And what chapter is that? I think it's chapter 78, and I would say it's pages 527 and 528. So that is a removal of the pituitary tumor. With a hypersecreting tumor of the adrenal cortex, adrenalectomy may be indicated. And then radiation therapy, which includes that stereotactic radiosurgery. They can use that on the pituitary gland to shrink it. Patients with adrenal cortex hypersecretion are at high risk for complications associated with excessive cortisol and aldosterone levels. So osteoporosis may develop, and it's relative to the effects of cortisol on bone density. And it increases the risk of pathological fractures. So what happens is all this cortisone decreases your bone density. So that is one of the complications of adrenal hypersecretion. In patients with hypercortisolism, secondary to exogenous corticosteroid treatment, an abrupt withdrawal of the medication can result in an acute adrenal crisis. So that's something you want to be aware of. Elevated serum glucose may complicate the management of diabetes in patients with that disorder. So if they have diabetes mellitus and you're giving steroids, you got to be, very mindful of that. And then if they have an adrenal cortex hypersecretion, like a pituitary tumor or adrenal cortex tumor, again, complications with an underlying diabetes mellitus, you really have to watch for that. GI bleeding is a big one. When you give steroids, you probably always know that steroids are usually given with propranolol or another acid inhibitor. GI bleeding develops because of with cortisol, it decreases the mucus production in the GI tract. It decreases the blood flow, and it releases hydrochloric acid, secondary to the effects of the cortisol, which all leads to this GI bleeding. So you're checking, right? Darkened stools. I don't need to go over that. You guys all know what we're looking for when we're looking for GI bleeding. And then untreated hypertension can damage other organs, including the heart, the kidneys, and the eyes. Cardiac arrhythmias are associated with that severe hypokalemia as well as hyper. And so we have a final connection check for adrenal cortex hyperfunction. So let's look at this. Promotes fat, protein, and carbohydrate synthesis. Which one are you going to see? It would be A. Promotes sodium and water reabsorption and excretion by the kidneys. What are you going to see in hyperfunction? Weight
B.
gain. Yes, peripheral edema and hypotension. It suppresses the immune response. So instead of that inflammation, that body-wide inflammation, they're going to have delayed wound healing because they're not going to have any immune response. It promotes glucogenesis. We will see hyperglycemia and increased excretion of K. In this case, we're going to see hypokalemia. I'm going to stop my share right here, and I am going to pause my recording.